Part 2 of our hypertensive crisis states. Today, we're going to cover hypertensive emergency. Now, for those of you who are not familiar with the hypertensive crisis states, especially with hypertensive urgency, no worries whatsoever. Hit pause. Go back into a previous post that I've done. You'll see the header, hypertensive urgency. You are going to want to familiarize yourself with that information, that material, because that lays foundation for what we're about to cover today. When you're done reviewing that information, just come on back, pick up where you left off. Classroom doors always open, and there will always be a seat available for you. For those of you who are very well versed in hypertensive urgency, lock in. Let's learn. Hypertensive emergency, just like its partner, hypertensive urgency, they both come with significantly elevated blood pressure readings of 180 over 120 or greater. The difference between hypertensive urgency and hypertensive emergency is that with hypertensive emergency, your patients will also have what is called target organ damage. What does that mean? That means that not only is their blood pressure astronomical, but as the result of that, one or more organ systems is now beginning to take a hit. One or more organ systems is beginning to break down and, for lack of a better term, suffer as a result of that blood pressure being as high as it is. More often than not, it's going to be one of three organs. It's either going to be the kidneys, the heart, or the brain. And that's not to say that any other organ system cannot be affected. It's not to say that, but more often than not, it's going to be one of those three. Well, how do you know? How do you know which one is being affected? This is why your patient with hypertensive emergency needs to get to somebody's emergency room. The first thing, or one of the first things that is going to happen when the patient gets to the emergency room, outside of an EKG being drawn, outside of getting a detailed history about how they've been feeling, how this accelerated blood pressure state came to be, one of the things that is going to happen is blood work. And with this blood work, the provider, the ED provider, is looking for which organ system may have been affected as a result. Now, if during the conversation part of this ED provider interview, if your patient has made statements such as, dizzy spells, headaches that are just, wicked, any blurred vision, keywords, blurred vision, then there is a possibility that the brain has now become affected and concerns for stroke come into play, or even a TIA have come into play. Diagnostic imaging is going to be done, with the absolute minimum being a CAT scan to see if there's any acute bleed or any intracranial abnormalities that warrant escalation of care. So this is how we find out if the brain has been affected. To see if the kidneys have been affected, blood work is going to be drawn. Blood work to look at what is called a basic metabolic profile. This is a profile or a series of lab tests that looks at kidney functions. And if you're looking for two particular values, I know off the rip, a lot of nurses are like, look at the creatinine. You are. That's one part. You're absolutely right. The other part, we're looking at the GFR, glomerular filtration rate. Not going to go into, the meat and potatoes of that lab value. Just know that those are the lab tests that you are looking for to see if there's been any immediate renal compromise. To see if there's been any heart compromise, you already know. Troponin lab values seem to be checked about for every reason that somebody comes into the emergency department. But in this case of hypertensive emergency, it is quite appropriate to draw troponin levels. Now, if you do find compromise in any of those three organs, then of course, consultants will be called in to do their respective workup and get your patient into a safe state, or get those organs some relief. Now, what do we do about the blood pressure? Remember, because we're still dealing with astronomical blood pressure. This type of hypertensive state, we have passed the point of oral medications. IV medications need to be put into play. And what type of IV medications, or which specific IV blood pressure medications, that is going to be individually tailored by the provider at the time. There are some times when a single dose of an IV blood pressure medication is sufficient to bring the blood pressure down to the point where you can then transition into oral medications. That it's very possible, very plausible. However, typically, well, as has been my experience, what typically happens is these hypertensive emergency patients get admitted to the hospital, and they will get started on a continuous infusion of IV medications, usually nicardipine, though again, other medications can be used. In my hospital, it is typically nicardipine. The goal with these patients and bringing blood pressure down, like, you don't want to bring it down dramatically. Don't do that, because you risk what is called hypoperfusion. Think about it. Think about it. Somebody comes into the emergency department with super high blood pressure, 220 over, 100, 110. We don't know, as clinicians, we don't know how long their body has been in this hypertensive emergent state. We don't know. Could have just been today, could have been a week, could have been a whole month that the blood pressure has been like this. We don't know. The longer a patient's blood pressure has been in these exceptional states, the more time those organs have gotten adjusted to living in that emergent state. And if you take that blood pressure, that blood flow away quickly and dramatically from those organ systems don't know what to do. It's almost like a shock state. So you want to gradually bring that blood pressure down little by little, within a certain time frame. You don't want to risk hypoperfusion, especially to the brain, definitely not to the heart. But nonetheless, that's the point with employing continuous IV medications for hypertensive emergency. Anyhow, getting to the point of hypertensive emergency, more often than not, this state even comes about because of non-compliance with medications. That's the primary culprit across the board. And it's not to say that it's the only culprit, but it is typically the primary culprit across the board. Medication non-compliance. I don't want that to be a negative connotation that, you have some patients who just refuse to take their medications. That's not the case. That's not the case. As a provider, it is vital that we are objective. We remain objective. We listen and we do not judge. All right. This is where you have a conversation. Nurses, you can have the same conversation with your patients at the bedside. If they are non-compliant with medications, find out why. Why? Because there's ways that we can help the healthcare community. We can help. Is the non-compliance due to the patient not having agreeable effects from the medication that's been prescribed? Maybe the medicine gave them some unwarranted side effects, some adverse effects. It happens, but you have to let us know, patients. Did the medicine give you GI upset? Did it cause you a rash? Did it make you, too dizzy? Whatever the case, if there are adverse effects, we can help. Was the medicine not affordable? Ask that question. Nurses and other clinicians, ask that question, because again, there are alternatives that we can employ to make sure that compliance is, as best as possible. There's assistance programs that the case managers might be able to utilize, some copay assistance cards or indigent care programs. We have resources. We just need to know what you need from us. Did you not have access to the pharmacy? Maybe the medicine is affordable. You're doing all right with it, but you just can't get to the pharmacy. Again, let us know. Let us know. I'm trying to think, is there anything that I left off? That's pretty much the bulk of it. So hypertensive urgency, you've got blood pressures of 180 over 120 or greater in the absence of symptoms. No symptoms whatsoever, no target organ damage. That is urgency. Emergency, You've got the same elevation in blood pressure, but this time now the body is starting to talk back to us to say, no bueno, this is not good. I'm starting to become affected. You've got target organ damage by way of symptoms and diagnostics. You're going to have to get admitted to the hospital. High-powered blood pressure medications will be used. Consultants will be called, and we are going to get to the bottom of why the blood pressure medicine that you were prescribed in the outpatient setting has not made its way into your body to do what it needs to do best. That's going to wrap it up for today. There are other parts of this series that I am so excited to share with you, like a little bit about preeclampsia, not a whole lot, because y'all know I don't do OB. I don't. Cardiology gets called in periodically in the hospital for our obstetrics patients who are having some poorly controlled blood pressure. So I'll share with you my limited knowledge about that. We're also going to talk about permissive hypertension. That's a good one. That wraps it up for today. Everybody have a fantastic day. Nursing students and new graduate nurses, I know this is a lot of information. Stand strong. You are doing great. You really, really are. Nursing students, stay focused with nursing school. You got this. You got this, all right? We'll see you on the other side of your NCLEX. You have a brilliant nursing family that's waiting on the other side. And despite what, certain political views may say, this is a profession. This is a profession. We won't get into that. Y'all take care. Bye.